Let this hearing come to order. Good afternoon. Welcome to the Budget Subcommittee number 1 on Health and Human Services, where today we will hear matters related to health as were presented in the mid-year revise. As always, the committee appreciates the presenters being very brief, and we will have public comment. We'll have 1 minute for each speaker. We want to save the balance of time for questions that committee members have on these items. I will announce that on May 26th, the subcommittee will hold its final hearing where we will vote on all measures. I'm sorry, May 24th. Let me correct that, on May 24th. So with that, we will prepare to get underway, and we will call our panelists for our first item on the Emergency Medical Services Authority. Committee is pleased to welcome the Director and Dr. Howard Becker, as well as the Chief Deputy Director, Dan Smiley. We'll also hear from Finance and LAO in public comment. We're ready whenever you are. Welcome.
Hey, Chair Thurman and Assemblyman Bonta and Harper. My name is Dr. Howard Becker. I'm the Director of the Emergency Medical Services Authority, and this is Dan Smiley. We were asked to comment on the notice in the May revise on the mobile field hospitals. And the questions we were asked specifically was, how is this purpose that was set out in the May revise different from the original purpose? And what I would say is that this represents a redesign of the program to work within the parameters that basically the budgetary realities, and allows us to use these resources in a more flexible fashion, and also to make them available to other state agencies. So while it does obviate the use as an acute care hospital, it allows use as a lower acuity medical facility, as a shelter, as either a general population or a medical shelter, or as even a general command center, or any other use that would be appropriate during an emergency. They could be used even for hospitals for triage and stabilization. So it maintains the investment in the facility and in the durable equipment that comes with it. It will not. We do not anticipate a cost to EMSA, because we currently have the staff to manage this program. We have an existing facility that is capable of storing one of these facilities, and along with our other mobile medical assets, and we intend to keep it there. And the other 2 facilities we would have to are yet to be determined where they would be stored, if they would go to another department or agency, or be maintained in their current location, which is donated space by FoodLink. There may be additional, the program is not completely delineated at this time. We've talked to a limited number of other state agencies. There is considerable interest, however, and eventually there may be we may have to figure out how to transport it, costs associated with transporting, if it's going to be stored somewhere else. There may have to be training of any partners who want to use this, and we'll have to integrate it into our standardized emergency management system in terms of determining the best use, how to mobilize and initiate use of these for the most pressing priority during any emergency.
Thank you, Dr. Becker. Anything else on the presentation?
I would leave it up to you if you have questions. Well, I guess I'll add that this still allows us to utilize this integrated with our other programs, especially with our medical teams, like our California Medical Assistance teams, which have been supported by the legislature and in the administration. And we have other teams like Medical Reserve Corps teams and specialized medical teams from medical health systems that could use these for medical care. Like I say, it would not be used at the level of an acute care facility without a significant need for requesting equipment, at the time of need.
Thank you. Were you going to add something, sir? Thank you. Anything from the Department of Finance? Anything from the LAO's office? Any committee member questions? Seeing none, any public comment on this item? Any public comment? Seeing none, we will thank you for that presentation. We'll move on to issue number 2, changes to the Medi-Cal estimate. We welcome Marie Cantwell from the Department of Healthcare Services. We'll hear from Finance and the LAO's office and public comment. Duly noted, we're glad to have Ms. Kent here. Welcome, Ms. Kent.
We are throwing you a curveball today.
We receive it well. We're happy to have you.
So apologies, Jennifer Kent, Director for Department of Healthcare Services. Mary Cantwell's out ill today, so I got called up from the triple leagues. So if I really screw it up, it's because the expert is not in the room. And
we are sorry that she's not well, but you are always hitting a home run in our committee. We're glad to have you.
We'll see how this goes by the end of the presentation. So first off, according to the agenda, you had asked for us just to kind of briefly go over some of the largest changes to the Medi-Cal estimate. I think of note, the caseload is projected to hit 14.1 million, 70% of which is an increase in the optional expansion population. So again, growth is continuing in the overall caseload, but I think it has started to steady off just a little bit, but still a significant number of individuals receiving care through our program. The overall general fund expenditures in the budget are down by $1.4 billion. Primarily, most of that is due to the managed care organization tax, of which is a different agenda item for later on. So 1.1 of that is attributable directly to the MCO tax. There are some notable items that we want to just call out in the estimate. There's about a $7 million change due to the minimum wage increase. This is directly in relation to some of the both waivers and nursing facility rates that we pay and have pass-through requirements. So there's a $7 million general fund cost there. We are accounting for about $88 million in general fund costs for moving individuals from the regional centers over into Medi-Cal managed care for the provision of behavioral health treatment. We have a change, and again, it's on the agenda as well later on, of about $130 million in general fund savings due to the implementation of the new federal rule and federal upper payment limits on pharmacy. You heard, I believe it was last week, about the settlement related to our fiscal intermediary and replacement system with Xerox, and so there's a $41.3 million savings due to the Xerox settlement. Starting today, as you know, we have started batching children into full scope Medi-Cal coverage. The estimate contains an additional $45.4 million increase in costs associated with the implementation of SB 75. A lot of this is due to both increased caseload projections as well as just a cost increase in terms of the rates that we have. The NQI wrap, there's a loss of about $32 million in general fund because we are proposing to delay the implementation of this particular program until 2018. As part of the MCO tax that was negotiated with the legislature in February, there were other costs and forgiveness of certain items, and one of those is the forgiveness of the DP-NIF retroactive recoupments. That's a cost of $106 million in general fund, which is accounted for in the estimate. And then lastly, there's a very small population of individuals that are currently receiving waiver services through Department of Developmental Services, and because of the movement of individuals receiving those services into Medi-Cal managed care, there's about 400 children that are institutionally deemed, meaning they have been found eligible for services based on their own individual status as a child. Under Medi-Cal rules, the income of the family is considered, and for these 400 individuals, they're not eligible for Medi-Cal, and so they cannot transition over. We have an additional amount of about $1.1 million general fund in the budget this year to work with an outside organization to help ensure that these children, when they lose services in March of 2017, so we have a little bit of time, obviously, to work on this, that we're ensuring that they not only have health coverage through some other mechanism, but that the services that they're receiving are also carried on by the new receiving entity, because obviously there's a mandate to provide BHT services also on the commercial health plan market. So with that, I will stop and take questions.
Thank you. Anything from the Department of Finance? Anything from the LAO's office? Any committee member questions? Mr. Bronta.
Just a quick follow-up question. How are you? Good afternoon.
I'm
Thanks for being here.
Thank you.
On the minimum wage,
Sure.
those increases, what positions are those typically that we're talking about, and how many are there?
Primarily, those are individuals that work in our skilled nursing facilities, and so we have rates that we pass that we account for in terms of how we pay the nursing facilities. And so individuals that are of minimum wage levels within those skilled nursing facilities, if there's an increase in the minimum wage, there's an agreement between us and those facilities that we have passed through. So the costs for the increase in the minimum wage get passed to us, and we pay those costs. So I think the bulk of the $7 million is attributable to costs for minimum wage workers in our waiver programs, which are pretty small, but the bulk would probably be coming through the skilled nursing facility.
Thank you.
Sticking with your baseball theme, it looks like we have you through issue 9, and so there are so many innings. Why don't we go ahead and move on to?
Are there 9 innings in baseball too? Okay.
Of course, you knew that, so we know.
I wasn't 100% sure, but I thought I would ask.
We know that the director is joking, but
Okay.
Let's see if there's any public comment on the Medi-Cal estimate. Any public comment? Public comment.
Linda Way with Western Center on Poverty. Thank you. Want to start off by thanking the department on implementing the Health for All Kids. That's a momentous occasion, as well as our support of the managed care organization tax and the revised assumptions for the federal waiver. Would like to note, in terms of the Medi-Cal backlog, there are still about 23,000 individuals who have not received eligibility determination within the 45-day period as of August 2015, dating back to August 2015. And so those are something that we would continue to want to work with the department on. Thanks.
Thank you.
Jennifer Snyder on behalf of the California Association of Health Facilities. We do appreciate the department's estimate and their recognition of some of the minimum wage costs that we will see in our skilled nursing facilities in the next couple years. We still remain concerned about the estimate. We think it's substantially low. The $7 million we don't believe actually recognizes what some call the ripple effect, or the concern that we have a lot of employees that are very close to the minimum wage. Many of them do receive the minimum wage, and we'll see that increase. But many employees, actually, we will raise their salaries, their wages, based on that pressure, which is overall a very good thing. You know, we're going to see a lot of our employees' wages move up over time, and they'll move up very quickly because of the quick increase in our minimum wage in the next few years. At this point, at least in our communications with the department, they're not recognizing those cost pressures, and those are substantial cost pressures for our facilities. And so we're very hopeful hopeful that in our discussions with them, they'll recognize that, and our facilities can be paid through the Medi-Cal program for those additional costs. Because right now, just the minimum wage increases are being recognized in that Medi-Cal estimate.
Thank you. Any other public comment? Madam Director, if you wanted to redirect on anything related to the wait time or the issues, questioning the amount and the
Sure.
the rate, and I would also add on that yesterday was a very special day to be able to acknowledge the implementation of SB4, that healthcare for all undocumented children, as well as just a banner year on the MCO tax and support for individuals with developmental disabilities. We certainly appreciate the partnership of the administration and your department on all of these items. Having said that, if you wanted to redirect on the concerns about waiting times and the
Sure,
estimate.
I can speak to both. The redeterminations, we had a fairly significant stakeholder discussion about those issues yesterday, in which we shared the data with the cases. We acknowledged, in partnership with the counties, some of the research and analysis of who those individuals are still is being done, and a lot of this is done down at the county level. And so if individuals are over the 45 days in terms of processing, what we are starting to suspect is that these may be individuals with either duplicate applications or some other anomaly in which they may already have coverage, but they abandoned that application. There was a lot of systems challenges with the implementation of CalHERS and the entire just bringing up of that entire system in 2014. And so some individuals submitted applications 60, 70 times. And so we have put into the enrollment and eligibility system a lot of fixes to do that, but we suspect that some of these cases are not necessarily true cases, in that the individual is not still waiting for an eligibility determination. They have either applied and come through a different door, or they there was a slight change in their name, or if their case index number was different and it was not done correctly. So we are working with the counties. I don't think that we think that there's 23,000 people out there that just don't have a eligibility determination, but I think we owe it both to you and to the stakeholders to come back and say what we know more about those cases, because we're still trying to work through who they are and when they came and how long they've been in certain places. As far as the minimum wage, I think we would acknowledge that the only costs that we're accounting for in terms of the minimum wage pass-through right now is strictly for those individuals that are being paid minimum wage. To the extent that their wages rise, those are costs that we're accounting for. To the extent that there are other individuals that are being paid, say slightly above minimum wage, and that there's a pressure there, we acknowledge that there's a pressure, but as has been our practice in the past, and I think it's a conversation that we're obviously willing to have, but we only acknowledge that we are directly responsible for the costs associated with the minimum wage increase and not for raising the other salary levels.
Thank you. We know that this is an ongoing conversation, and we look forward to further discussion on that item. Why don't we move on to issue 3, Managed Care Enrollee Tax Administration, issue 401, as we move forward. Ms. Kent?
Can I use a baseball analogy?
You're on a roll. Why not?
Okay, all right. And I'm not a baseball person, but I think there's a Grand Slam analogy that should be used, in that we got our letter from the federal government this morning saying that they had approved the MCO tax, and so very exciting. I think that we're pleased with the outcome. There was one small change in the methodology in which the federal government had asked us to make a change to one specific plan to make it more broadly a provider category that included both Medicaid and non-Medicaid plans. And so the removal of that one plan from the overall tax drops the net effect for the state from about $4 billion over the 3-year period down to about $3.75 billion. But with that, approval came, and we got it this morning, and so we're good.
Great news, and good use of the baseball analogy.
Right. And in 3 years, we will do it all over again. Are there other questions on that? Because that's pretty much all that there is to be said on the MCO.
Anything from the Department of Finance, LAO's office, committee questions, public comment? Oh, I'm sorry, committee members.
Congratulations. I know how hard you worked on the MCO tax over many months, and how many different scenarios you worked through and how many changes there were. The CMS created some new challenges with their new guidance, and you met those challenges. And today was a big day. So congratulations, and you've really helped California with your work. Thank you.
Right. And I would just like to say, it was a really amazing team effort. We had great technical folks. Mary Cantwell, and an Excel spreadsheet is a beauty to behold. But then, you really have to give a lot of credit to the plans who worked really hard in what was a very difficult thing for a lot of them to work around in terms of taxing a line of business that was not always something that was taxed. And so, again, a lot of different pieces fell into place, and we are quite pleased with the outcome. So.
Thank you, Mr. Bonta. Thank you. We do have some public comment.
Sure. Good afternoon, Mr. Chair and members. Tam Ma with Health Access California here in support of the department's request for resources to implement the MCO tax, and also to express appreciation to the department for all their work on the MCO tax, as well as implementing Health for All Kids. Thanks.
Thank you.
Good afternoon, Jennifer Alley with the California Association of Health Plans. We're, slightly relieved to hear that the CMS has approved the tax models. We don't have to rethink anything, but we would like to acknowledge the hard work of the department and their staff and a combined effort for that. So thank you.
Thank you.
Linda Way with Western Center on Law and Poverty. We supported the MCO tax and support the additional positions.
Thank you. Issue number 4, Federal Managed Care Regulations Workload Issue 402.
Correct. So just for purposes of background, there was a draft federal rule that was released by CMS last year that dramatically enhanced and increased the workload on states for their Medicaid managed care programs. We as a state had issued a series of letters to CMS and voiced concerns about a couple of key provisions. Several other key stakeholders in California also echoed those concerns, including the Hospital Association, the Health Plan Association, CMA, SEIU. The things that we had the biggest concerns around were around directed supplemental payments. There were some modifications made to that by CMS in terms of they put directed supplemental payments such as the hospital fee in California on like a 10-year phase down period. I think we don't know enough today based on the fact that the rule came out just a few weeks ago. It's over 500 pages of very, very small type. I think that there's a lot that we still have to internally both understand, and then working with a lot of other individuals, both inside and outside the departments, decide whether we need to make changes or can we continue to do things in a certain way. But that was certainly a critical modification that we had expressed concern about. There was another concern around rate ranges and how states can use those rate ranges to pay or pull down federal dollars for a lot of other things. They have not made as many changes in that particular area, and so it's not that it's necessarily impossible for us to continue doing what we're doing, but there are going to be changes that are going to have to be made. They're going to have to be made prospectively, and it will just be more complicated. Those, along with the provider enrollment, there was a provision in the draft rule that would require all providers, regardless of whether they're in managed care or fee-for-service, to come through the state's fee-for-service enrollment. We had concerns and expressed those concerns about access to care, because even if a physician does not want to provide care in fee-for-service, they would still have to come through the state's fee-for-service enrollment portal. This would also, by our reading of the draft rule, encompass IHSS providers, especially because of the long-term care and home and community-based inclusion of those provider types, which, for purposes of illustration, we have about 150,000 providers in our master file today in fee-for-service. IHSS has about 450,000 providers. So only in the CCI counties, but you can just get a perspective of how significant a workload that would be. They removed that provision from the rule, but there is a bill pending in Congress that does the exact same thing. So we think that that will eventually come our way. And so we continue to have some concerns about the implementation of that. Stepping back for the rest of the rule, there were significant changes in appeals and grievances around network monitoring, access standards, how we do some of our quality metrics and monitoring. And so we are seeking 37 positions in the budget to implement certain parts of that rule. We know that it will require a lot of coordination both with the plans. We will have to do work not only with our Medi-Cal managed care plans, but with our county mental health plans, as well as our drug delivery system, because those are included in the rule because of the nature of a network that they now are, as well as working with DMHC in terms of trying to make sure that we have kind of a cohesive and coordinated approach to the rules that are now under Medi-Cal as opposed to what's going on in the commercial market. So for those reasons, that's the kind of the significant number of positions that we're asking for in this particular May revision request.
Thank you. Anything from the Department of Finance, from the LAO's office? Committee member questions? Any public comment? Any public comment? Seeing none, we'll move on to issue number 5. Institutionally deemed behavioral treatment, population case management, expedited contract trailer bill, issue 560.
Great. So this is something that I alluded to earlier before, is that these are individuals that are currently being served under the DDS waiver. There's approximately 400 children under the age of 21 that are only receiving BHT services. And because of the nature that they have been institutionally deemed and as a sole individual by moving over into a Medi-Cal benefit, which is now what the state plan requires, they are no longer eligible because they fall outside of the income limitations as a family calculation. So rather than completely eliminate services on March 2017, which is when that will become effective, is we're proposing $1.1 million in general fund to identify an outside organization or contractor to work with each of these individuals and their families to ensure that they have coverage and that they have some continuity of care or plans in place for how they're going to continue to receive BHT services once that benefit is no longer available through the DDS side.
Anything from Finance, LAO's office? Committee member questions? Any public comment?
Linda Way with Western Center on Law and Poverty. We support the department proactively seeking to ensure that these children remain covered. We also would like to note that in terms of BHT services, there have been delays in accessing BHT services as well as the comprehensive diagnostic evaluation.
Thank you. Issue number 6, a covered outpatient drugs final rule trailer bill.
Sure. So we have trailer bill that we're proposing. This is, again, in compliance and coming into accord with a federal rule that was recently released in terms of drug reimbursement and changes to how drug programs are paid under the Affordable Care Act. Some of the key notable things that we will be seeking in terms of the trailer bill proposal is we're modifying the federal upper payment limit definition. We're also adding a professional dispensing fee. So that was one of the main changes in the rule, is that you are now paying pharmacies on their actual acquisition costs for their pharmaceutical purchases, as well as establishing a professional dispensing fee that includes the pharmacist's professional services associated with dispensing the drug. We are undertaking some work to find what that actual professional dispensing fee is going to look like. We obviously will be coming through the budget for changes of what that looks like. And then these are all going to have to be effective no later than April 1st of 2017.
Thank you. Anything from Finance, from the LAO's office? Committee member questions? Any public comment?
Good afternoon, Chair and members. Brian Warren with the California Pharmacists Association. We do have some issues that we have addressed to some of the committee members in relation to this matter. It's not in relation to the department's specific proposal, but due to the timeline of how these federal regulations are being implemented, there were some cuts or some recalculations to how reimbursements are made that began last month. And as the director mentioned, the final implementation of these changes, of some additional changes, won't take place for another year. So there's a 1-year period during which pharmacies will receive a pretty significant cut to their reimbursement. We do think we have some changes that can be made in the form of amendments to the trailer bill language that was released. And I think I will cede the rest of the time to some other folks.
Thank you.
Jennifer Snyder on behalf of the National Association of Chain Drugstores. The cut that Brian Warren mentioned is a federal upper limit, and it's requiring states to restrict payment to pharmacies to a certain limit for multi-source drugs. And that will affect, at least my client has determined it will affect at least 70% of those drugs that are dispensed, and will be a cut to pharmacies of over 30%. We don't as much have a problem with kind of phasing up or actually coming up with a reimbursement structure that gets at the true cost, but then our dispensing fee also has to get at true cost, and right now it's really low. So we've asked for some type of supplemental payment in the meantime while the department goes through the process of coming up with a study that will come up with that proper dispensing fee, but we need some help in the next year to make sure our pharmacies can stay in business with that substantial cut that's in place as of April of this year.
Thank you.